Hello, and welcome to our educational webinar on fatty liver disease and MASH. We are happy to have you with us for this informative webinar. I am Farah Douglas, President and CEO of the Liver Health Foundation. We are an approved nonprofit patient advocacy foundation serving Greater Los Angeles and beyond. Thank you again for joining us. Recent studies estimate that between 38% and 42% of U.S. adults have fatty liver disease. According to FDA, approximately 6% of U.S. adults have the most dangerous form of fatty liver disease, or MASH. This latest finding points to the importance of early screening and intervention, particularly in communities that may be at greater risk. Having MASH carries a significant risk of future cirrhosis, especially in the presence of obesity and type 2 diabetes, and it even increases the risk of developing liver cancer. It is believed that cirrhosis caused by MASH will soon be the most common cause of liver transplantation in the United States. We are proud to be able to offer the latest information about MASH in tonight's webinar and respond to your questions. Now our disclaimer. Please remember, information given by our experts is not a substitute for advice given by your own physicians or healthcare providers. We do not endorse doctors, hospitals, medical centers, or treatments. This program has been made possible by an educational grant from Madrigal Pharmaceuticals. We thank Madrigal for their support and for their commitment to raising awareness of MASH. In tonight's program, we are honored to have some of the best hepatologists with us. It is my pleasure to introduce Dr. Brian Horwich, who generously has accepted to be the presenter for tonight's program. Brian Horwich, MD, MS, is a transplant and general hepatologist treating patients with a broad range of liver-related conditions, including cirrhosis, hepatocellular carcinoma, alcohol-associated and autoimmune liver diseases. Originally from Chicago, Dr. Horwich earned his undergraduate and master's degree in bioengineering from the University of Pennsylvania. He received his medical degree from the Keck School of Medicine of USC in the Health, Technology, and Engineering program. He stayed to complete his internal medicine residency at Los Angeles County and USC Keck Hospital. This followed by gastroenterology fellowship at the Mount Sinai Hospital in New York, where he served as chief fellow. Dr. Horwich returned to Southern California to complete an additional fellowship in transplant hepatology at Keck Hospital of USC. His clinical and research interests include fatty liver disease, immune liver disease, liver transplantation, and alcohol-associated liver diseases. Dr. Horwich has received many awards and recognitions, including Alpha Omega Alpha, Medical Honor Society 2021, American Society of Transplantation Trainee and Young Faculty Mentoring Program 2023, Eric Lemmer Memorial Fellow of the Year Award at Mount Sinai Hospital 2024. Dr. Horwich, welcome to Liver Health Foundation. We are thankful for your support and participation, and we are ready for your presentation.
Thank you so much for having me and for the introduction. I'm going to go ahead and share my screen here. I just want to confirm that everyone's able to see it and also hear me.
Yep. Yes.
Okay, wonderful. So I have no financial relationships to disclose for this presentation. So really want to keep this a little bit broader and really focus on kind of the broad strokes of fatty liver disease or MASH, and we'll talk a little bit about the terminology. We'll go into a little bit about how common MASH or fatty liver disease is, how do we make a diagnosis of MASH, and what treatment options are available. And so for those of you that have joined us that are patients or supporters of patients with fatty liver disease, you may have noticed that this is a disease that really goes by many names. And so historically, it was originally called fatty liver disease. There's other terms that you may see in your notes from your provider, or as other clinicians, you see notes from other specialists here. So hepatic steatosis, steatotic liver disease, non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, metabolic dysfunction associated steatotic liver disease, metabolic dysfunction associated steatohepatitis, and then another terminology that encompasses what is non-alcoholic fatty liver disease and alcohol-associated liver disease, or MET-ALD. And so it helps a little bit to talk why this nomenclature exists and why we use it to describe the condition. And so in MASH, and the M is metabolic dysfunction, so related to metabolic syndrome. So common features of metabolic syndrome are diabetes or impaired glucose tolerance, hypertension, high cholesterol, or excess body weight, specifically excess body fat. We cheated a little bit by using the A for associated so that we get to MASH. S is for steatotic, meaning the medical term for fat. L is liver, and D is for disease. So that's MASLD. So that's the non-inflammatory form. And then when we get to MASH, is metabolic dysfunction associated, steato or fat-related, hepatitis, or inflammation of the liver. And talking about this pathway, which is something that may have come up for you before, is when we look at a normal liver, which is a low amount of steatosis, generally less than 5 to 10%. We see well-functioning hepatocytes and a normal kind of a normal ratio of fat to functioning liver cells. As fat accumulates in the liver in response to metabolic syndrome, you actually see the liver grow in size because that fat takes up space, and that the fat ends up taking up a significant proportion of the liver cells. And really, once we see greater than 20 or 30%, which you're a much higher risk for developing inflammation related to that fat. And as that inflammation continues over years or decades, you develop scarring in the liver. And then that scarring, as that progresses further, can lead to complications of liver disease related to high pressure in the liver, which we refer to as portal hypertension. And as that scar tissue replaces enough healthy liver cells, you're left with a very advanced liver disease or even liver failure, which is cirrhosis and decompensations of cirrhosis, and increases the risk of developing primary liver cancer. So the question that we often get asked is, how common is MASH? And so in 2019, and again, that's a few years ago at this point, it was estimated that up to 30% of adults in North America and Australia had MASLD, so the non-inflammatory component, and with 5% or upwards of 7% having the inflammatory component or MASH. As of 2024, and this is actually recent data that came out, MASH was the second leading indication for liver transplant in the United States, very close behind alcohol, but a growing indication. And there's some mathematical modeling that suggests that if we don't make significant changes on a population health level, that fatty liver disease or MASLD will affect up to 42% of US adults by the year 2050. And this is just from that same paper that did the mathematical modeling, just to show you sort of the expected growth over the next 30 years. Other questions that we frequently get are, what risk factors can affect someone's likelihood of developing fatty liver disease or MASH? So we know that as we get older, our risk increases. Certain ethnicities with an increased risk. So we see a significant increased risk in people of Hispanic or East and South Asian descent. There's genetic factors which also follow closely along with ethnicity, but there's a specific polymorphism called PNPLA3 that we know is associated with an increased likelihood of developing fatty liver disease. There seems to be an increased risk in men very slightly. And then we also know that there are a lot of unmeasurable things that affect the risk of developing MASH. So social determinants of health. So we know people of lower socioeconomic status are more likely to have fatty liver disease. Health literacy, which goes to healthcare decision-making and an ability to adhere to recommended treatment plans. And then also going along with socioeconomic status is access to certain types of food. And there's literature out there talking about how people who live in food deserts, which are areas where healthy groceries and healthy grocery stores are not as readily available, there's a much increased risk of fatty liver disease. And this chart just really just kind of demonstrates some of those adjusted risks based on different demographics. Another question that we get quite frequently is what symptoms can you expect from MASH? And the reality is the most common is having no symptoms whatsoever. And this is generally thought of as a silent disease because you can have fat in the liver and inflammation related to that fat for many years, if not decades, before you ever develop symptoms. And most people with MASH don't develop any symptoms or issues related to the disease until they have advanced fibrosis or cirrhosis. I will say anecdotally, and I'm curious what some of my colleagues have to say about this, we very frequently have people report that they have abdominal discomfort or pain in the upper abdomen in the area of the liver. It's not generally thought that this condition can cause pain, and there's a thought that maybe we're just diagnosing fatty liver in people with this pain because they're getting further evaluation that leads to the diagnosis. But the liver itself does not have pain receptors, but the capsule around the liver does. And so when there's significant inflammation or stretching of the liver related to rapid fat deposition, you can see some pain related to this. There are symptoms that could be suggestive of underlying metabolic syndrome that we always screen for and look out for and can ultimately lead to a diagnosis of MASH. So if people that have uncontrolled or undiagnosed diabetes, we see frequent urination, blurry vision, excessive thirst. For people that have uncontrolled high blood pressure, we see headaches, dizziness, and really some of the worst complications we see are not even really related to the liver itself, but are those of cardiovascular disease. So things like stroke or heart attack. And actually people with fatty liver disease are much more likely to develop cardiovascular disease or complications of cardiovascular disease than they are to develop liver-related complications. So very important to assess for all of these things. And it's part of an important part of the care plan, which we'll get into in a moment. In looking at once you're suspecting a diagnosis of MASH, what diagnostic criteria do we use to establish that diagnosis? And so the first is evidence of fat in the liver on some form of imaging. Most often it's an abdominal ultrasound that's done for an evaluation of abdominal pain or some other reason. It's important that we rule out other causes of fatty deposition in the liver. And so there are medications that can do this. Alcohol use can be associated. We also see this for certain specific vitamins and supplements. And so that's part of the initial assessment that your liver specialist will do. And you need to have at least one cardiometabolic risk factor. And so these are you need at least one of these 5, and they're very specific in their cutoffs, but the way that I generally will speak about them with patients in clinic is body mass index over 25. And it's important to note that for people of East Asian descent, that cutoff is actually 23 or above. And that's because people of East Asian descent are more likely to have what's referred to as lean MASH, or more preferentially deposit fat in the liver at lower relative body weights. We also can use waist circumference. I will say in practice that doesn't get used so frequently, especially because BMI tends to be a much easier metric to measure and more readily available in the clinic. The second one is impaired glucose tolerance in some way, shape, or form. So that can be done through fasting glucose, or more commonly hemoglobin A1C. And so that would be a diagnosis of diabetes, or what used to be called pre-diabetes. We now favor the term impaired glucose tolerance because pre-diabetes has this implication that you're definitely going to develop diabetes, which is really not the case. But anyone that has impaired glucose tolerance is considered at risk, and that's considered one of, if not the strongest predictive risk factor of developing fatty liver disease. Other diagnostic criteria include elevated blood pressure, high cholesterol, specifically with high triglycerides, or actually low levels of what's often termed as the good cholesterol, which is the HDL. So our initial evaluation will generally consist of establishing the diagnosis. So looking at height and weight, vital signs, BMI. We'll send blood counts, liver tests, and then screen for diabetes and high cholesterol, and then some form of imaging to confirm that there's fat in the liver. Usually that's done with an abdominal ultrasound because it's generally cheap and easy to obtain. The other part to this is really identifying, are there any other underlying conditions that could lead to the development of fat in the liver, or does someone have any other risk factors that could increase the risk of developing steatohepatitis, so inflammation related to the fat, or lead to or have progression of scarring at a much quicker rate because something else is going on. So we'll always review medication, supplements, and alcohol use is a big part of this. And then we'll do an assessment for other underlying liver disease conditions that can affect the liver. So we'll send iron studies because if you have iron overload, it can accelerate the rate of scarring. We'll check for a rare condition called alpha-1 antitrypsin deficiency because individuals who are carriers for the mutation are at an increased risk of developing scarring in the liver. We'll check things like thyroid function and also screen for a rare condition called Wilson disease, which is very uncommon but can cause fat in the liver, and sometimes people with Wilson disease are misdiagnosed as having MASH before they ultimately receive that diagnosis. Once we identify and clearly diagnose someone with fatty liver disease or MASH, the next step is staging the disease. So the way I talk about this with patients in clinic is once we know that once we get a sense of where things are, we need to know how far are you on this continuum of how much fat is in the liver, and where are you on the continuum from little to no scarring to more advanced scarring. And so the initial risk stratification, which oftentimes happens in the primary care setting, is through some of these non-invasive testing that are based on readily available blood testing. So the two most commonly used are the FIB-4 and the APRI. So the FIB-4 is directly calculated based on age and based on blood tests, and this is something that's readily available in the primary care setting. And then the APRI is also just the ratio of two labs that are readily available. It's more straightforward to calculate, but it's a little bit less reliable, and we're definitely seeing the FIB-4 more commonly used. This is the official recommendations from the American Association for the Study of Liver Diseases regarding how you risk stratify people and decide whether or not they should be referred to GI or hepatology specialty care. And you can see sort of in the top in the blue here that a FIB-4 score that's calculated to be greater than 2.67 sort of generally is recommended that they be referred to a specialist. And FIB-4 less than 1.3 generally considered low risk, and then between 1.3 and 2.6 is considered intermediate risk. I will say in reality, what ends up happening is that even if the FIB-4 score is not particularly high, if someone has inherently other risk factors or they have other metabolic conditions, then they often get referred to us for consideration because there are treatments that we use for fatty liver disease that also are helpful for some of these other conditions. When it comes to staging the disease, we grade the steatosis, or the amount of fat in the liver, from 0 to 3, and we stage fibrosis from 0 to 4. So 0 is little to no scarring, and 4 is advanced scarring or potentially cirrhosis. As far as tools available to stage disease, so the most commonly used is transient elastography or FibroScan in terms of something that has a really good sensitivity and specificity. It's a non-invasive test that uses ultrasound waves to assess how much fat and scarring there are in the liver. It takes about 5 to 7 minutes to do. It just requires fasting for 4 to 6 hours prior, and it's available in our clinic in Santa Monica, and a lot of subspecialty clinics will have this technology. It can be affected by a lot of other different things, and so including people who have a body mass index greater than 35, it can be less reliable. So sometimes follow-up testing is needed. What's becoming the gold standard of non-invasive testing is MRI elastography, or MRE. And that's a full picture of the liver, and where you go in an MRI scanner and there's a device that gets strapped to your abdomen that sends a pressure wave that allows the estimation of scarring in the liver for the entire liver. It's a more expensive test. Insurance sometimes doesn't pay for it, and there's very limited machines available in Southern California. And so it can be a little bit challenging to get someone in or scheduled for that. There's also blood-based testing like the Enhanced Liver Fibrosis score or testing. Ultrasound elastography is a probe that's sort of an add-on to existing ultrasound technology, but there's a lot of variability in the reliability of that test. And then there's other blood-based testing like FibroSure, FibroTest, or FibroMeter. This is just a little bit of what you can expect from a FibroScan, so the first item I discussed. So this is what a typical probe would look like, and this is what the report looks like when it comes back to us, and then we help interpret it and report it back to you. But you'll see the blue number on the top on the left is the controlled attenuation parameter, or CAP score. That's an estimation of how much fat is in the liver And based on the specific disease that we're looking for which we're looking, lets us know that there's sort of a direct corollary that we can give you a grade. And the same goes for the amount of scarring in the liver, the E number, the orange number on the top right. That's an estimation of scarring. Really, though, when we talk about treatment options for MASH, the mainstay of treatment is addressing the underlying risk factors that cause the disease. And so I often will tell patients in clinic that the liver is kind of like a window to what's going on in terms of overall cardiometabolic health. It's a large organ. We can see it on imaging. We have good tests to monitor degrees of inflammation that are occurring, but it actually is really showing us what's happening potentially at a microscopic level in terms of risk for things like heart attack and stroke. And I mentioned this earlier, but people with MASH are more likely to experience a major cardiovascular event than they are to ever experience a liver-related complication. So the first line of treatment is first looking at things like diet and lifestyle. And so the Mediterranean style diet, and this is something that I think Dr. Garcia can potentially speak on with more expertise as well. But the way I'll describe it in clinic to patients is thinking about using leaner proteins like chicken and fish, using olive oil as your primary cooking oil, and even olive oil spray if you feel like that's adequate for your cooking preparation, and then limiting complex carbohydrates. And I think a big issue that comes up for a lot of people is what the idea is of a serving size for some of these carbohydrates. And so a half cup of rice or one slice of bread is typically less than most of us will have at the table or when we're out to eat, but really trying to limit the intake of carbohydrates because they can cause spikes in blood sugar as well. And kind of leads me to my next point, which is about high sugar beverages. So sodas, juices, even juices that are advertised or marketed as healthy, you really have to read the labels and see what the sugar content is in them. Because if you're having a beverage that has 14, 18, 20 grams of sugar, that spike in your blood sugar that you'll have as a result of consuming the beverage I'll describe it as kind of like fuel to the flames. It drives inflammation in the liver and can increase the activity of fatty liver disease. And we see that when there's spikes in blood sugar. Limiting sweets. And one area of more significant interest of late is there's some emerging data about caffeinated black coffee. There's been studies looking at 1 to 2 cups of caffeinated black coffee, and that's black, not adding a bunch of sugar and other mix-ins, may have some metabolic health benefits for the liver. There's some theories as to why, but we don't know for sure. So we get questions a lot about decaffeinated coffee. There's potentially some benefit, but we can't say for sure. Another rule of thumb that we like to give patients is that the longer the name of the coffee drink, the less likely it is to have benefit for you. So by the time you have a double chocolate chip cappuccino, that's probably not going to be such beneficial for your liver. As far as medical therapy goes, and this is something that we get a lot of questions about as well, and for which Dr. Janna and Dr. Garcia have a lot of expertise as well. Medical therapy for fatty liver disease is only approved for people who have stage 2 or stage 3 scarring on non-invasive testing. The reason being is that the fatty liver disease MASH moves very slowly. It takes years to go from little to no scarring to liver-related complications. And so to study it effectively, the people that have been studied are those that have the highest likelihood of developing symptoms of liver disease. And those are individuals that have not yet developed cirrhosis, but do have moderate to advanced or stage 2 or stage 3 fibrosis. So we're very excited to have the approval of resmetirom or Rezdiffra. It's a once daily pill that has weight-based dosing. So individuals under 100 kilograms have an 80 milligram dose versus 100 milligrams for people above 100 kilos. And it's a liver-specific medication that upregulates the metabolism within the liver. So it acts on a very specific receptor called the thyroid receptor hormone beta, which is more liver specific. It helps clear fat from the liver, and by clearing fat, it allows the inflammation to calm down, preventing progression of disease, and stopping the progression of scarring. And in a small proportion of people, we also see reversal of scarring. It's generally a very safe and well-tolerated medication, but some of the more common side effects that we see are nausea, diarrhea, and abdominal discomfort. Those symptoms tend to be worse within the first 2 to 4 weeks of starting the medication. And so oftentimes when we have people start, we'll let them know this is potentially not going to be like this forever. And we really encourage people to stick with it at least for a few weeks. And oftentimes we use medications to help with some side effects to get people through. So anti-nausea medications or anti-diarrheals. And it does interact with some medications that a lot of people with MASH are also taking. So we'll always ask about, are they on statins? Because there's certain maximum doses of statins that you can be on. And then Plavix, which is an antiplatelet medication used for things like heart attack and stroke, are also, we have to adjust the dosing. The downside to this medication, it really does not have any direct impact on weight loss, and people for whom excess body weight are a significant contributing factor to their disease, it's not helpful at sort of treating that underlying cause. And we generally will reach for this medication either if there's insurance reasons why people can't be on it, if they have intolerance or for some reason cannot be on GLP medications, or people who have lean MASH or should not lose any further weight if we're worried about malnutrition. The other FDA-approved medication that we have for fatty liver disease is semaglutide or Wegovy, and there was a lot of excitement when this approval came through last year. It's now actually available. Historically, it was a once weekly injection was the only option. As of January of this year, we also now have a once daily pill. Everyone starts at relatively the same dose, which is a low dose to monitor for side effects. And then the dose is titrated slowly over several months. It can take up to 6 months to achieve a target dose. This should say a GLP receptor agonist. And so it binds to the GLP-1 receptor and works in multiple organs throughout the body. And Dr. Garcia is an expert in this and can talk a little bit more about that as well if there's further questions. But really it works on the liver specifically, but also has greater metabolic effects. So it helps with blood sugar regulation, and semaglutide was originally approved as a diabetes medication by controlling blood sugar, helping with body weight, excess body weight loss. We see a reduction in fat in the liver, decrease inflammation and progression or prevention and scarring progression. And it seems to be, from what we can tell, maybe more effective than resmetirom. More, we think, because of the weight loss aspect and the improved blood sugar control. However, the main downside to these medications is the side effects, and ones that are very common are nausea and vomiting, particularly as we're going up on dosing, constipation or other changes in bowel habits. Hair loss is one that is becoming an increasingly recognized side effect of the medication, and is definitely something that is of significant concern to our patients. So that's something that we'll always discuss before starting treatment. Gallstones and pancreatitis. And so for people who have had multiple episodes of pancreatitis, sometimes this medication is not the best option. And we see significant weight loss with this medication and other benefits and cardiometabolic risk factors. But we have to monitor people carefully while they're on this, because we don't want people to lose excess body weight, and particularly not losing lean muscle mass, because we can see malnutrition and other adverse health outcomes related to that. And in sort of the reality, even if we write the medication and there's a good reason for it, there's a lot of issues that we've had with insurance coverage, and there's a lot of back and forth specifically with Medicare, but it sounds like as of July 1st, it will be approved again for specific indications. But we spend a lot of our time writing authorizations and appeal letters to insurance companies to get the medication approved, just because they're expensive for insurance companies to pay for, and there's a lot of hurdles that get thrown our way, even if we feel very strongly that people need them for their liver health. When it comes to monitoring treatment response, so once we start someone on treatment, we'll repeat the fibrosis testing generally around 6 months after initiation. And so that would be repeating FibroScan, usually the same modality we use to assess the scarring to begin with. If scarring is relatively the same or improved, we generally consider that a treatment success because there's no progression. If scarring is getting worse, then we'll discontinue and consider an alternative therapy. So if someone was on Rezdiffra, we'll try Wegovy or vice versa. And we'll be carefully monitoring for side effects and routine blood work to make sure people are not developing liver test abnormalities, which can happen with Rezdiffra or other complications. The duration of therapy is one that comes up quite frequently, because we get asked, well, how long do you expect that I'm going to be on this medication? And so we always tell people it's going to take us at least 6 months to assess whether there's a response. So the downside to a slow moving disease like MASH is that it takes us a long time to understand if a treatment is working. I generally set the expectation that someone is going to be on the medication for at least 1 to 2 years. But really, if it's working, we want people to stay on it as long as they possibly can. Same idea that if someone someone has diabetes and they get put on insulin, it controls their blood sugar and their blood sugar looks better, it doesn't mean that the disease isn't there. It just means that we're controlling it better. And so I like to set the stage that you may be on this medication for a very long time, and we hope that you're on this medication for a long time because it means that it's working. And as far as other things that are very important to medical treatment, so exercise, and I think that's something that doesn't get discussed enough sometimes, and that's weight-bearing physical activity, so things that help maintain and build muscle mass. And the more that you can shift body composition to higher percent muscle mass, the better. Muscle has a higher metabolic rate than fat tissue, and so actually building muscle mass can help maintain body weight loss and drive further body weight loss with physical activity. And then nutrition counseling is critical to prevent malnutrition, especially people that are doing a more aggressive diet plan or on GLP medications and losing a significant amount of weight. So just to summarize some of the key points, so MASH or MASLD is increasingly common disease, and MASLD is affecting at least 1/3 of US adults and growing. Important that we identify it early so that we have interventions to prevent the development of cirrhosis and other health-related complications. And medical therapy, or I should say medical liver-directed therapy is available for people with stage 2 or stage 3 scarring, but really all managing underlying risk factors is the most critical aspect to preventing progression of disease. And I just want to thank everyone for the opportunity to speak with you.
Thank you, Dr. Horwich. That was a fantastic presentation. Really appreciate it, and cleared up a lot of the questions that people had sent to us. So thank you for doing that. So now it's time for us to start the second half of our program, which is the roundtable discussion. We have 2 other great hepatologists that are going to join us at the round table, so I'm going to introduce them now. I am honored to introduce Dr. Michael Garcia. Dr. Garcia is an assistant professor of medicine in the Division of Clinical Nutrition at UCLA Health. He is board certified in internal medicine and is a physician nutrition specialist. Dr. Garcia completed his undergraduate education at Harvard College and received his medical degree from the University of Maryland School of Medicine. He completed residency and training at Harbor UCLA Medical Center, where he also served as chief medical resident. Dr. Garcia joined the UCLA faculty in 2019. He has presented various topics at national conferences and has authored important book chapters and scientific articles. He specializes in medical nutrition, including utilizing nutrition and internal medicine in the prevention and treatment of malnutrition, intestinal failure, cancer, obesity, metabolic conditions, and gastrointestinal condition. Dr. Garcia, welcome, and thank you for your participation.
Thanks for having me.
Thank you. I am pleased now to introduce Liver Health Foundation's good friend, Dr. Sean Chanda. Sean Chanda, DOFACP, AGAF, is an attending physician, Division of Gastroenterology, Olive View, UCLA Medical Center, Health Sciences, Associate Clinical Professor, David Geffen School of Medicine at UCLA. Dr. Sean Chanda earned his Bachelor of Science in Microbiology, Immunology, and Molecular Genetics at the University of California, Los Angeles. He received his medical degree with honors from Western University of Health Sciences and completed his residency in internal medicine and dual fellowship in gastroenterology and transplant hepatology at the University of Cincinnati. He is a highly experienced hepatologist with medical expertise in general and transplant hepatology. He has held faculty positions at the University of Utah and the University of Cincinnati, where he was assistant professor of medicine. He co-developed the multidisciplinary liver tumor clinic at the University of Utah Huntsman Cancer Institute. Dr. Chandra has been published in peer-reviewed research journals. He has been a principal, investigator, and sub-investigator for multiple clinical trials. His clinical and academic interests include liver diseases across the spectrum, cirrhosis, liver cancer, liver transplantation, and liver transplant oncology. Dr. Chandra is a fellow of the American College of Physicians and fellow of the American Gastroenterological Association. Dr. Chandra is a member of the Liver Health Foundation Medical Advisory Council. Dr. Chandra, welcome. We appreciate your continued support.
Thank you for having me on, Farah.
Thank you. So now we will start our roundtable discussion with all of our three doctors. Over the past few days, I have received questions from the audience as well as those who couldn't be with us tonight. I have submitted the question to our presenters, and I know a lot of them have been answered already through Dr. Horwich's presentation. But to start it, I want to ask a question that was kind of unique and came to us. I would like to pose a question that was sent to us by a pharmacist. She's asking, how can a pharmacist increase awareness of MASH question mark? What can a pharmacist who is dispensing and reviewing MASH and medication and GLP-1 do to take better care of new and current patients? So Dr. Horwich, I'm going to pass it to you, and then we can go around and ask everybody these questions.
It's a great question. Exciting to hear that our pharmacist colleagues are also very engaged in the care for these patients. I think one very kind of straightforward thing is that you can encourage people that are receiving medications for diabetes already to speak with their primary care doctors about whether or not they should be screened for MASH. And so there's been some discussions actually about whether every person with diabetes should be screened, because the prevalence of fatty liver disease is significantly higher in people with diabetes. When they've done some modeling, they've realized that it's just very challenging to screen that many people, and the amount of people that would be screened and not end up having any sort of change to their care plan is quite high. But as a pharmacist, if you're dispensing insulin or Jardiance or any of these medications that are used for people with diabetes, you can at least raise awareness and then let them know to bring it up with their primary care doctor, or if they already follow with the GI specialist, about getting screened.
Dr. Garcia, would you like to add something to that?
I think just in terms of the medications, I know a lot of questions came up about the GLP-1 medications. One of the potentially beneficial, but I think also unfortunate, is the accessibility to not only the medications that are prescribed in specific concentrations that have been studied, but there are a lot of clinics and other pharmacies that have made these available in compounded versions. And so I think when a pharmacist is speaking with a patient, as Dr. Horwich mentioned, depending on other conditions, other medications, I think just being aware of if an individual is on these medications, where they're obtaining it, something we see and I see quite frequently. And so I think making sure that an individual knows what has been studied, what maybe hasn't, what the risks of things that have not been studied in certain concentrations. Because the unfortunate reality is, I think, accessibility and for some of these online programs is very prevalent, and not everyone is aware or given the potential downside and side effects and risks when they sign up for some of the programs.
Dr. Chano?
Yeah, I think it's an interesting question. I was going to echo what Dr. Horwich said, which I think is that if we realize that 2/3 of all diabetics have MASLD, it's important for anyone with diabetes to be following up with their primary care provider and see if they potentially have fatty liver disease. It's also important, I think, in the pharmacy and really any healthcare professional setting, is to remember that these medications are approved in conjunction with diet and exercise. And so, it doesn't necessarily take a specific type of health professional to encourage that these medications are needing to be used in conjunction with some of those changes, whether it's a Mediterranean diet or implementation of activity of 150 minutes and muscle strengthening during the week, twice a week. So specifically in the pharmacy realm, there are statin interactions that need to be modified for resmetirom. I think it's important to remember that as well. But I think putting it all together, kind of talking to your primary care provider, implementing diet, implementing exercise, taking these medications carefully, and maybe not being over reliant on them, and kind of putting in the other metabolic work that needs to go into it in conjunction with these pharmacotherapies.
Thank you. Another question is, do you see more emphasis on dietary education with fatty liver patients than in the past? Also, have any studies come out with outcome numbers where this strong emphasis on dietary education has been applied? Any of you who wants to answer, go ahead.
I'll start off. Yeah, I think as everyone mentioned, the emphasis on dietary pattern, exercise, it's always been important. I think something I've seen as the initial pharmacotherapy, the medications were used, maybe very frequently, and when they were covered by insurance plans a little bit more readily, say 4 years ago or so. I think the initial reaction was like, maybe there's not as much of an importance on this, even though it's something we've always stressed. I think as availability of the medications, and maybe some individuals cannot always stay on them long term for a variety of reasons, which we can go into. I think the emphasis from what I see from patients has, with dietary pattern and exercise, has come to the forefront again. And something we've always emphasized, the Mediterranean pattern, we know not just for fatty liver, but a lot of the metabolic conditions Dr. Horwich mentioned, diabetes, cardiovascular disease. We know it's a pattern that is realistic to maintain long term. And it allows for a little bit more wiggle room without saying eliminate this or eliminate that. And it really emphasizes exposure over time to good quality food. It's not so strict. It's not so specific on, this amount of that or this amount of another nutrient. And we do know that this emphasis with a certain degree of weight loss, with certain percentages up to 10%, can lead to improvement in the fat content and the inflammation. So I think something we've always known, something we always try to emphasize, it should be really the foundation upon which all of these other measures build upon. It's not mutually exclusive pathways, so it's something that will always be important regardless.
Dr. Horwich, Dr. Chandler, anything else to add to this question?
I think there's been a long period of time where there was not enough of an emphasis on diet, or if we've looked at very specific diets and very kind of rigid ways. And I think we know that people that are in clinical trials tend to do better than the average population. And I think that's especially true in some of these dietary intervention trials, because people tend to be more adherent to a treatment plan if they feel like they're being watched more carefully, and whether that's just because they want to do what they feel like they're supposed to be doing, or because they have more support when they're part of a clinical trial. And so there's plenty of data out there on dietary interventions. I think I actually, when I talk to patients in clinic, tend to not focus so much on the weight loss aspect, because I think really it's not about losing weight, it's about losing excess body fats or excess body weight. And so the higher your BMI, the more likely you are to have excess body weight. But really we want people to change their body composition. And so I often will tell patients, I would rather you not lose a single pound, but convert 10 pounds of fat into muscle than for you to lose 15 pounds and have all of that be muscle. And I think especially a lot of people for whom that have struggled with body weight and being told to lose weight their whole lives, that one more doctor telling them that they need to lose weight is not anything different than what they've already heard. And so I think actionable information in terms of here's what, Mediterranean style diet, exercise that focuses on building muscle mass, I think are a lot more helpful guidance and help people have good measures of success as opposed to the sort of standard, don't eat this, definitely don't eat that. And I think another thing that's important to emphasize is that perfect is the enemy of great, and having a very rigid diet that you follow really well for a few months and then you burn out on it, and then your diet the following few months is really not so good, is not good for your health, and in some instances might be worse than if you had just done a good job the entire time. So people also have to be kind to themselves, and if you have some times where you're not as on track is okay. It's really just about creating a sustainable strategy, and for some people that's being very strict at the beginning and loosening things up as time goes on, or starting off small and then building on that when it comes to dietary interventions.
Dr. Chandra, do you want to add anything to what the other doctors said?
I mean, I agree with Dr. Garcia. I agree with Dr. Horwich. I think, I agree it's difficult to emphasize the weight loss, and we actually know that even though the response rates may be better in clinical trials, they're actually still fairly poor in the placebo arm. So if we look at the ESSENCE trial for semaglutide, the placebo rate of weight loss was about 2% as compared to 10.5%. And so I think it's important for us to, I usually, when I talk to patients, I try to do it not from a place of stigma and from talking to them that this is a physiologic disease that starts with insulin resistance. It is a metabolic disease, and there are processes here that are difficult to control. And so I think if we talk about exercise, very interestingly, we know that folks that do exercise regularly and implement the strategies actually can have some steatosis reduction. Now, it may not necessarily translate to steatohepatitis improvement or fibrosis improvement, but it does have an impact itself. And I agree with all of the sentiments that just changing the quality of the food and getting some regular activity is probably more important, than maybe dropping a single pound, although it is ideal to have, closer to 10% body weight loss. But I think we need to take it from a place of, pathophysiology and how does the disease work, and not from a place of, hey, you need to just lose weight. So.
For people who already living with liver disease, say they were born with biliary atresia or they have autoimmune hepatitis, is it safe for them to try to lose weight through GLP-1s, or how does that impact their situation, autoimmune hepatitis or biliary atresia? How does that work?
I think autoimmune hepatitis is a really interesting and challenging situation because the way that we monitor disease activity with autoimmune hepatitis is with liver tests, and the way that we treat autoimmune hepatitis is with steroids oftentimes, and that can lead to weight gain, blood sugars going up. And so for people that have risk factors for metabolic syndrome and a diagnosis of autoimmune hepatitis, it can be really difficult to, one, assess and understand what's going on, and two, to help manage treatment for them. And so we also have to think about some of the implications that using medications can have on, or medications for MASH can have on autoimmune hepatitis treatment plans. So if someone would benefit from Wegovy for fatty liver disease, but the Wegovy makes them so nauseous and vomiting that they're not able to keep their autoimmune hepatitis medications down, then we have a serious problem in terms of their long-term liver health. And so it's definitely not mutually exclusive, and we definitely have people that have autoimmune liver disease and autoimmune hepatitis that also use GLP medications, particularly because they tend to have diabetes and other risk factors for which the GLPs can be helpful. But it definitely requires a closer level of monitoring, and you really have to understand what's going on if you see some liver test abnormalities.
Dr. Chandra, anything else?
No, I mean, I think Dr. Horwich said it all for this one. Certainly it's important to recognize that patients can have multiple diseases that affect their liver. Even if you have AIH, even if you have biliary atresia, you could still have MASLD, as we know that 38% of the population has MASLD. So certainly, yes, if you're taking a GLP-1 and you cannot take down your azathioprine, for example, for your autoimmune hepatitis, that is a problem. But it is important to just recognize that there can be overlap of diseases. And I think it goes back to Dr. Horwich's point that when you are initially seeing somebody with elevated liver chemistries or with fatty liver, to recognize it, we need to exclude secondary causes of steatosis and secondary causes of chronic liver disease. And I think that is something that in the primary care realm, it's very easy to be able to say, well, you've got metabolic comorbidities, you've got elevated liver enzymes, you have steatosis on imaging, this is the diagnosis, and let's go from there. But it's really, really important to exclude the other cause of liver disease. So I always try to make it a point when I'm educating healthcare professionals to be able to do that and to recognize that we still need to be comprehensive before we solidify the diagnosis.
Dr. Garcia, would you talk a little bit about your specialty and how you help liver patients as far as nutrition goes and healthy habits to what to eat, what not to eat? And then also, please, if you can, touch on people who, because of their physical conditions, cannot do much exercise. What are we going to do with those people who are overweight and also have fatty liver disease? So
Yeah, that's definitely a challenge. As a group here, I think the dietary pattern, the physical activity that has been emphasized here, it is one of those foundational things that we really need to make sure there's some structure to. As has been mentioned, the medications are another tool among many tools, whether to change body composition, whether to kind of affect fat accumulation or body fat percentage. I tell patients it's one of those things that it doesn't happen quickly. We don't want it to happen quickly. And so if we start a medication that just addresses one component of what a challenge may be, and we ignore, don't put enough emphasis on dietary pattern and exercise, then we're probably doing someone a disservice. So something I don't want to say 100%, but as I'm meeting someone, I think making sure that there is some form of structure to dietary pattern and exercise, because that's the exposure we get every day. Doesn't mean it has to be perfect where someone's having perfect meals and there is no perfect meal. Doesn't mean they have to go to a gym 7 days a week and exercise for 2 hours. But if it's scattered, just like sleep, if we sleep well Monday through Wednesday and then we stay up Thursday night, we're exhausted Friday, Saturday. If we eat one meal this day, 3 meals the next, and it's scattered in terms of structure and timing, our body gets stressed from that. And so that foundation is some degree of regularity with eating. The Mediterranean pattern, it allows for that. It focuses on whole foods. It allows variation in terms of, what we're used to eating, what we may grow up with. It's not just this specific, like you got to eat these vegetables and these proteins. So it allows for some of that flexibility. I always focus on kind of timing, number of meals, that single or one or few ingredient foods that I really emphasize to individuals. The physical activity, it's kind of a silly analogy, but I tell everyone to treat it initially as brushing their teeth, right? We do that every day. We don't ask. The reward is very high. It's, multiple different things, but we do it for 2 minutes. A lot of people have in their mind, like, I need to do this amount of exercise to make it worthwhile. And I think that's a great long-term goal, but consistency, if we can build that from the start, that's really most helpful. So that pattern, I always like to make sure there's some structure before I consider medication. If someone cannot exercise for one or many different reasons, we are a little bit more cautious because we still want to provide benefit. We know if weight loss occurs quickly, the risk of losing muscle is a little bit higher. And so if there's not really a mechanism for maintaining muscle, one, I would be cautious about when the right time is to start a medication. Two, making sure we go slow with dose adjustments. It's not where we need to go to a higher dose every month and lose X amount of weight very quickly. Slower, steady, making sure, if it's a matter of getting enough protein as the main modality that we can target, that we do that. So it is challenging. for some, we don't always start a medication because maybe the benefit of it doesn't outweigh that risk of losing muscle. So we just need to be careful with that.
Right. Dr. Chanda, did you want to say something?
No, I mean, I think, I know we're talking a lot about diet and exercise and certainly the impact of GLP-1s and losing muscle mass. Some of the studies have estimated up to 1/3 loss of muscle mass. So it is important to do it slowly and give the diet and exercise a trial. But I also just want to speak to the advancements in pharmacotherapy. I mean, this is a disease now that we know that MASH is the second leading cause of transplantation in the United States. It's the first leading cause of transplantation in women. Patients on average have 2 times the amount of cardiovascular mortality. When we look at patients that have F2, stage 2 fibrosis, we know that the mortality rate is 10 times what it is in the general population. Then we go into F4 cirrhosis, and it's 40 times. So there are huge advancements in pharmacotherapy, thanks to the advent of resmetirom, thanks to the advent of semaglutide. And we have multiple medications that are being studied. And it's really an exciting time to be in hepatology and to be able to offer our patients this discussion about a comprehensive evaluation of liver disease, MASLD, MASH, the implications thereof, and also recognize that patients that have advanced fibrosis have a very high risk of rapid progression to cirrhosis over even a short period of time. That 20% of patients that have F3 fibrosis will become cirrhotic in about 2 years. So I think as much as we're talking about diet and exercise, which is very important, we need to talk about all of these things, but we also need to just understand that pharmacotherapy has come a long way. If you look at the studies in and of themselves, you may look at the response rates and say, well, perhaps it's in a quarter of patients, or perhaps it's in the absolute percentages look small, but these are meaningful differences in patients that have been dealing with metabolic disease for their entire lifetime. Particularly their adult lifetime. We even know that children are now getting MASLD, right? So I think it's important to recognize that this is very comprehensive, and we need to also think about pharmacotherapy where appropriate and trying to decrease the risk of accelerated disease progression in patients that are most at risk.
Dr. Horwich, did you want to add something to the answers?
I think Dr. Chanda and Dr. Garcia kind of said a lot of things that I sort of had in the back of my mind. So I don't know if I have that much to add to what's already been said.
Okay, we're running out of time. We have many more questions. I know we can't do justice to MASH in 1 hour, so hopefully we will retouch again before the end of the year, have another webinar. But there was one question that was very odd to me. I'd never heard it. It says, is it true in some cases fatty liver disease could shrink the brain? I've never heard that before. Is it true?
I would say I haven't heard sort of there's if you think about the factors that contribute to underlying fatty liver disease, it also contribute to cardiovascular disease. So for people that have chronic ischemic disease, including ischemic strokes, where you can see brain volume loss related to that. I could imagine maybe that's where those two things could be related in people that have poorly controlled or advanced cardiovascular disease as well as fatty liver. But to my knowledge, I haven't heard of fatty liver disease as being a direct cause for brain volume loss.
Dr. Garcia, Dr. Chanda, have you heard that before from anybody, any of your patients? No?
I have nothing to add. That I completely agree with Dr. Horwich's comments.
That is so strange. I never saw. They thought maybe this person who is asking the question, maybe that is one reason for Alzheimer for some people. I don't know.
I think also something, because fatty liver disease is so common, it's more likely to have fatty liver disease and something else that's maybe not so related than it is to have fatty liver disease and something that's caused by it. And so when you think about 1/3 of the US adult population having this condition, then there's a lot of people that have fatty liver disease and XYZ things in addition. So it may be there are many people that have are affected by both of those things, but not that one's directly causing the other.
Well, thank you so much. I can't believe how fast this roundtable discussion went, and I have a lot more questions, but we will revisit this topic again before the end of the year. I just want our audience to know that our doctors are here as volunteer physicians, They care deeply about liver patients and are sharing their expertise with all of us in support of the efforts we are putting forward in helping liver patients and raising awareness of liver disease. So my personal heartfelt appreciation to all of our presenters and doctors. Thank you. Now I want to also personally thank Dr. Horwich. We are honored to have you with us tonight. Thank you, Dr. Garcia. You brought up many good issues that we had not talked about before. Thank you. And thank you, Dr. Chanda. We appreciate your continued support of our efforts. Thank you to Madrigal Pharmaceutical for their educational and patient advocacy grant and support. We really appreciate Madrigal's support. So now I want to ask everybody to please join us on September 12th for liver health screening, health fair, and Walk for Your Liver Los Angeles in Santa Monica. This year we have added free non-invasive liver health screening. We just heard about how early detection is important, and this screening that we provide will be simple, non-invasive, and the result will be given to you the same day by a doctor who is going to be there monitoring the screening of it. But we also do health screening, we will do the health fair, and we will do our favorite walk for your liver, Los Angeles, which we will walk to the pier in Santa Monica and back. We will also host a webinar on a rare liver disease called LAL-D. I'm gonna try to pronounce it. It's lysosomal acid lipase deficiency, or LAL-D. The webinar will be on June 16 from 6 to 7 Pacific time. Please join us by visiting our website, liverhealthfoundations.org. We thank Alexion Pharmaceutical for the support of LAL-D webinar. Our presenter will be Dr. Kohli from CHLA. Thank you, Dr. Kohli, for accepting our invitation. Liver Health Foundation is on all, Liver Health Foundation is in all social media. Please visit us. We put our news or the date for our webinars and everything there. So thank you for joining us this evening for this important webinar. We hope to see you at our upcoming webinars and liver health screening in Santa Monica on September 12th. We wish you all a happy and safe 4th of July. Please be well, stay safe, and happy birthday, America. Thank you and good night.